Okay, hello everybody. My name is Will Herrick, and this is my case study for medical biochemistry. Okay, so case one here, we have a 16-year-old female is recently diagnosed with a deficiency of muscle glycogen phosphorylase. She and her family are concerned and ask the following questions. Based on what I know about skeletal muscle glycogenolysis and muscle metabolism, I will respond to each of these questions with a thoughtful answer that describes metabolism in these various scenarios in language that my patient will be able to understand. And I will be sure to include the role of relevant metabolic pathways, specific enzymes, and stimulus for their activity. First off, the patient asks, I'm not sure I understand the issue. Can you explain to me how muscle glycogen is used normally during exercise? Absolutely. When exercising, muscles need energy to move and work out. This energy is a sugar stored in the muscle called glycogen. Glycogen is made up of multiple glucose molecules linked together and stored within the muscle. When exercising, your body uses epinephrine, aka adrenaline, to signal the muscles to break down glycogen into glucose. The enzyme that does this is called glycogen phosphorylase. Once broken down, the glucose is converted into a molecule called ATP, which provides the muscles with energy needed to perform. In your case, you have a deficiency in glycogen phosphorylase, which does not allow your body to break down glycogen as efficiently, causing you to have less energy and tire quicker. The patient then asks, I really like to take long walks. Will I still be able to do this with my friends? And the answer is yes, with some exceptions. You'll still be able to go on walks with your friends, but you will tire much quicker and also feel fatigued a lot more. In this case, it is recommended to take more breaks, make sure you're fully hydrated, and listen to your body when you're running low on energy, as it would make sense. Question three, the patient asks, as a result of this deficiency, will I need to get up at night and maintain my blood glucose levels? Although in this condition, your body's normal blood sugar levels are harder to maintain, especially in these periods of no eating, like when you're asleep. But this does not mean you'll have to get up throughout the night. As long as you maintain a regular and consistent diet that contains normal meals and snacks, this should help keep your energy level stable. The patient finally asks, do I need to worry about producing excessive lactate during intense anaerobic exercise? And I said, when you exercise intensely, you and your muscles run out of glycogen and start using another pathway called anaerobic metabolism. This process generates energy quickly, but also produces a byproduct called lactate. With your deficiency, your muscles might not be able to use glycogen effectively, which means they could rely more on this anaerobic pathway. This can lead to an increase in lactate, which might cause discomfort, such as muscle soreness or fatigue, and could affect your performance. You may need to moderate the intensity and or duration of your exercise to avoid this excess lactate buildup. Case number two. A previous healthy 2-month-old female presented with jittery spills several hours after breastfeeding. Her mother reports she has not given the baby anything to eat other than breast milk since birth. The baby has only recently been sleeping for no more than 2 hours between feedings, and that's when the mother reports these symptoms started. Laboratory results are consistent with hypoglycemia, low blood glucose, but are otherwise unremarkable. Epinephrine is administered and there is no increase in blood glucose, but there is an increase in blood lactate. Physical exam reveals that the liver edge 4 centimeters below the right costal margin. Precision of the right chest and abdomen confirms hepatomegaly, or enlarged liver. Blood glucose levels increase after breastfeeding, but she cannot maintain blood glucose levels within a normal range during fasting. Based on the information above, which of the following is more likely to be a diagnosis of the patient? Okay, so I'll start with the correct answer, and that is answer C, glycogen storage disease, or inability to use glycogen. This is due to a couple reasons. First, the infant symptoms. The jittery spills and hypoglycemia. This indicates an inability to maintain blood glucose levels when not fed. The glycogen storage disease commonly deals with hypoglycemia due to the acceleration of glycogen in the liver. Also, the fact that when epinephrine was administered, there's no increase in blood glucose, but an increase in blood lactate, which can mean a failure in glycogenolysis. Okay, now let's take a look at the incorrect answers and see why they were wrong. First, we have answer A, hereditary fructose intolerance. This condition typically presents with symptoms after the introduction of fructose, which is not applicable in this since the baby has only been breastfed. Also, separate symptoms can be seen when this condition is introduced, such as vomiting, hypoglycemia, jaundice, and liver damage. Since these conditions are not visible and the baby has only been exposed to breastfeeding, we can rule this answer out. Answer B, galactosemia. This results from a deficiency of one of the enzymes that metabolize galactose. This leads to the accumulation of galactose-1 phosphate and other metabolites. Symptoms often include jaundice, hepatomegaly, vomiting, and potentially sepsis-like symptoms. When the baby is exclusively breastfed, galactosemia symptoms typically manifest in the first few days of life and would be more acute. The absence of classical symptoms like jaundice or failure to thrive in this case means this answer is much less likely. Finally, the final incorrect answer, glucose 6 phosphate dehydrogenase deficiency. This condition is associated with hemolytic anemia and does not primarily present with hypoglycemia and hepatomegaly. Symptoms include jaundice, dark urine, pallor, and fatigue, typically precipitated by infection, certain medications, or even dietary triggers. G6PD deficiency is not primarily associated with hypoglycemia or hepatomegaly. The symptoms presented here focus on hypoglycemia and prolonged fasting, which is not characteristics of G6PD deficiency. Case 2 conclusion, the presence of hypoglycemia, elevated lactate following epinephrine administration, hepatomegaly, and the age of the infant all strongly suggest that the glycogen storage disease, answer C, is correct. The other potential diagnoses do not align with the timeline, depend on dietary factors that have not been introduced, or present with different symptoms. Thank you guys for watching my presentation. Make sure to leave some questions in the comments if you'd like me to answer them, and I will make sure to look back and check them out. Thank you.